How are you?
How you doing?
Welcome.
Hello.
Thank you.
America.
Good to see you. So Dr. Brown has done the first implant. Is that right? Number one.
Yeah.
So we got the originator here. So we know we have some slides. I can cycle through the slides, or you can.
Okay.
And we'll get started.
All right, great. So what do we got? The first one's up there. 4. So these are the new implants. Chris, you want to talk a little bit about?
Yeah,
these?
I do. I think
these are titanium 3D printed. It's amazing stuff.
Yeah, we as a company, AJ, we're really excited to bring these to market. So we started as a traditional posterior bone graft implant system,
Right.
And I think this is just the next evolution in that therapy. So we'll have a full complement of products now. So we do have titanium lateral oblique screws. For certain clinical indications, we have titanium versions of our posterior implants, and we're really excited to offer not just one type of implant, but more options to meet the clinical needs of your patients.
Oh, that's fantastic.
So yeah.
All right.
Yeah, so this next slide is just demonstrating the superiority of these new titanium 3D printed implants over allograft in terms of the bone growth into it. So at 5 weeks, it's got almost 4 times the strength of the allograft. And this is largely due to the design, the texture of these 3D printed grafts.
Yeah, I think a lot of people ask, why a titanium implant in general. We've all had good success with bone, and we like bone, etc. I think what you see from titanium and in the spine surgeon world, that's all they use. So we think that it has better, great bone growth characteristics. And actually what you see with these, we've done some research and studies on these, is that at 20 hours, these will actually start growing bone across the implant. So you'll get a lot faster fusion with these patients, and it has a greater potential for a long-term fusion as well.
So I think that's really interesting that you guys have used the technology to create this rougher surface that allows for a faster bone growth development as opposed to a smooth surface. So really, really great use of the technology.
Yeah, it's tough to tell, in VR land, but yeah, this has got a great surface where the bone will grow into it nicely.
Yeah, we can
to
show
like a
that.
smooth machine.
Once we
surface.
start showing the procedure, we'll have a camera that we can showcase on the hardware there up close.
Yeah, and it's really hard to see too, but on these posterior implants, if you hold them up to the light, they're completely porous and hollow. So they'll fill up with the patient bone marrow and immediately start reproducing
Perfect.
bone cells as well.
So the next slide is really demonstrating why I like the oblique approach. We have posterior approaches, we have oblique approaches, we have lateral approaches, but compared to the lateral approach, there's so many advantages. One, gluteal muscles, right? So there's no disruption of any of the gluteal muscle tissue, faster patient recovery, less pain for the patient. Up in the corner there's the big gluteal artery, some nerves, so there's less complications, no intraoperative bleeding, postoperative hematomas, increased pain from nerve damage. All of those are avoided by the lateral oblique approach.
And I think that's a big plus in this elderly community that we're treating, most likely for these types of diagnoses, right?
Yeah, absolutely. And then there's some intraoperative pictures just demonstrating the technique of how to get that screw in through that lateral oblique approach. We're coming from basically the PSIS, just lateral to it, and then crossing through the joint and into the sacrum.
Fantastic.
Yeah, and I think this is a really good diagram. Shows some more procedural steps, but I think this is a really good view of that hybrid type construct. So you have one screw, one titanium implant at the bottom, which is the construct that Dr. Brown uses the most. But depending on your patient, you may choose to use 2 screws.
Okay.
You may choose to use 1 screw, 1 titanium implant, 1 screw, 1 bone implant. It all varies depending on your patient and your clinical judgment.
So you have a lot of flexibility.
Absolutely.
That's fantastic.
Yeah.
So I think what we'll do is we'll have you start showcasing the procedure. We can move over to the views on the anatomic model here.
Yeah, well, so we'll get an oblique view.
So I think it's important. This bottom graft is the same implant as a traditional CornerLoc. So procedurally, it's very similar to the bone graft.
Yeah, the procedure is the same. So anybody that's done CornerLoc before is familiar with it. This is going to be, you'll feel right at home with this. We've already, let's take a shot there.
Take a shot.
Oh, this is this piece.
So come back to around 15 degrees.
Let's see, 15. Yeah, so that's a better picture there. So we've already gone ahead and placed this initial guide pin in like you would with a regular corner lock into the inferior aspect of the joint. Now let's go to a lateral. All right, so there's our guide pin, just like we would do, the regular corner lock. Our initial dilator is going to come in here. So place this down, and I'll hammer this down into the joint. It's a little tough on this model, but shot there.
Yeah, make
Coming in nice.
You're good.
Get your exercise today.
Yeah, it looks good there. So you can see the guide pin come back a little bit.
All right.
So we detach this, and then there's our working cannula. We'll slide over that. Here. Let's go over the top. Now we're going to hammer this down into place. Shot there. You get a heftier hammer. There we go. All right. So once that's in place, we can see that's seated into the posterior joint. Everything else comes out. And we're going to drill our initial hole here. All right, live. There we go. So once that's our initial pilot holes in place, we get the implant. Now the implant, it's got a little bit of a different holder. For those of you that are familiar with the original CornerLoc design, it just kind of screws into the back here, and that'll still go in just like how you remember it. So we get that down into place. Shot there, and now that's right into place. Now that is the smaller implant. We have two different sizes. This is two different. We do have a larger implant, which would take up quite a significant, larger footprint within the inferior joint there.
And you can see right there on the image, you can see right through that implant, which is actually really pretty cool.
Unscrews.
It doesn't obscure a lot of your vision. That's
Right.
And everything's out.
So it's kind of the same steps as we normally
So that's basically like the first part of your regular corner lock that you're familiar with, other than the type of graft that we're using in there.
Right.
So the next step is where we're going to place the screw. Okay, so this is what's new to everyone, unless you're already familiar with the, say a Rialto system. You come on top. So the way I like to really lay out our trajectory with this is, there's a couple different views here that are very important. You have your pelvic outlet view, which is tilting forward, your pelvic inlet view, tilting caudally, as well as your lateral view, which are probably the most important here. So we're gonna start with the outlet view. Basically, we're gonna tilt forward, square off the top of that S1 end plate. We do this because it helps visualize the S1 and S2 posterior narrow foramen. Ideally, what I want to do is drop a screw right between the two. Right. Let's see what we got there. All right, so not bad. Now, this is a little bit different model here, so than a real human, but what I would do is draw a line there, okay, on a patient, shot there, come down to 2, shot, draw a line somewhere in there. What I'm going to do is palpate now the PSIS. It's a little different. This is a real patient, obviously you can feel a nice PSIS, and then I go about 1 finger breadth lateral to where that PSIS is, and that's where I'll make my incision. Now the nice thing about this is that I can do this through a stab incision with an 11 blade. So it's about as minimally invasive as it gets.
So it's going to be a lot less traumatic than, say, a traditional lateral approach for SI joint fusion.
Oh, 100%.
Oh, that's fantastic.
100%. While avoiding all those complications. How thick this is, I got to go on a lateral. I'm coming through all that muscle, right? Artery that's in there somewhere, that you're not going to see under fluoro. And so you avoid all that. Here, I'm basically just coming over. I'm going to dissect. There's a little tiny bit of subcutaneous fat, and then you'd be right down onto where the ilium is. So this is our initial tool here, okay, for getting our trajectory. After I lay that out, I'm basically just going to get into here, and I'll just dock right there. So once I know that take a shot there. So once I'm at a spot where I like where I'm at there, now I got to get my trajectory. Okay, so there's the next, this is the inlet view, so we'll tilt all the way caudally. Now this is the inlet, but I also call this my safety view, because this is going to show you the anterior border of the sacrum, okay? What's anterior to that? You got bowel, you got some iliac arteries, all kinds of things you don't want to touch with metallic instruments. So let's see the shot there. And come down a little bit with it if you can. Able to move the sheet. Yeah. So with this, you can clearly see the anterior aspect of that sacrum. What I'm going to do here in this view is I'm going with my medial to lateral trajectory. So shot there, right? And this way, right? A little too steep here, shot, just perfect. So that's what I want to do with that. Now we'll switch to a lateral. So I might give this just a little tap. Make sure that's in a good position. Not going to move. So again, that is where we're going to get our medial to lateral trajectory. Now what I want to get is my cranial caudal trajectory, which I'll get in the lateral. Okay, so I'm going to just steepen this up a little bit. Right, there's that sacral prominence heading right towards that, and that's perfect. Now I'm going to tap that down. So now it's in a nice position here. I'm going to switch back to what I call the safety view. Again, so you will know that you're never going to go too deep with this instrument. There we are. You can see it nicely, so I'm going to hammer this the rest of the way home while holding that trajectory in place. Ideally, the patient's a little different in the model. We would get a little bit deeper than that.
I think you're there.
Yeah, this here for this.
In terms of, for those who are accustomed more to doing a bullseye technique, what training would you suggest that they do to become comfortable with this approach?
I mean, really, it's just getting comfortable with the views,
right?
And this. So a lot of people, their biggest concerns, I'm, putting this thing straight through anterior. I want to get to the iliac artery, all kinds of messy things. And I have to explain to somebody what I did. No, this is your safety view. You can never be more comfortable with knowing how far you can go by just looking at this inlet view and seeing where you want to go. It's very reassuring to see that. Guide wire goes down. Once the guide wire is in place, we'll just shimmy back and forth. All right, so we leave the guide wire shot there. Perfect, so our guide wire is down. Now we have a little hand drill. It's a little ratcheting hand drill. I can place this right over the guide wire.
Now, Chris, you use a power drill for the posterior anterior approach.
Correct.
And you use the hand drill for this. So what was the decision? Why not use the same power drill?
You can use power as well.
You can
for this.
Is this preferred? It just gives you more control.
To be honest,
power's there if you need it. So it's a lot of experience using Rialto system, which is a similar approach. And for there, you really need a power. But this system is designed in a way, and Chris is saying that there's something about the way that these, I just got a cloth.
Oh, okay.
This clot's a lot nicer. So the case I've done so far, I've had no need for power.
I see.
Yeah. And the design of the cutting edge of that reamer is such that you don't really need power. If you want to use it, you certainly can. But
it's there for you.
It's there for you. And I would also say the hole that we're creating for the posterior implant is bigger than the hole we're creating there. So
that's true.
Power makes some sense there.
All right. So again, we're in the safety view. You don't want to advance, with any of these instruments in any other view. This is your safety view. We're going to see the anterior sacrum shot there. And now you can go under live if you like. We don't need to. I'm just going to go down, shot, slowly advance, down, shot. Now once this has a safety stop, so once it hits the ilium, it will stop and it'll just spin its wheels right there, shot. It won't go any further. and then we can reverse it and back this out. Now, you could theoretically, it's possible to take out the guide wire, but what we do recommend is keep the guide wire in place for screw placement. We have 2 different screws, so you kind of, based on how much room you have when you're drilling, I mean, there we have a significant amount of room, so I'm going to use the larger screw here.
So based on your depth of the drill is how you size the screw?
Yep.
Okay.
Yeah, and essentially the depth of that drill is a 40 millimeter depth, which is the size of our smallest screw.
Okay.
So you use that to gauge the length of the screw that you're going to put in.
Okay,
So
great.
place the screw over the guide wire, and then the driver down and lock onto the screw, still in forward position, down to the ilium shot. Okay, and you just want to keep an eye that you're maintaining the same trajectory shot as the guide wire. Now this is a lag screw, which is a nice design over some of the other systems in that it will press down.
So yeah, explain that a little bit more. You were telling us about that earlier. What makes, what is a lag screw for the audience members that don't know? What's different about a lag screw than, say, your traditional regular type of screw?
Well, a regular screw will simply go across, a joint or 2 pieces of wood, and it won't actually pull them together.
Right.
Whereas these are designed, there's different ways to design lag screws. Some of them you can have smooth in one area of the screw and then just threads at the end, which will then pull it across. This is designed a little different with different size threads, so one will pull faster than the other as it gets in there. And you'll feel it tighten down. As soon as you get down to that ilium in the patient, you'll feel it tighten up nicely and it'll start pulling.
And because of the uneven lengths between the threads, that's what gives you that extra compressibility over a regular screw.
Right, so
which
you
is
see
nice.
the thread at the top is a lot closer together than the thread at the bottom. So once these top threads engage the ilium, they'll pull at a faster rate, which will compress that joint together.
Which gives you a little bit more comfort knowing that you're going to have that extra benefit.
Correct.
Yeah.
It's also going to compress onto the inferior graft and will help induce fusion is the feeling, because Wolff's Law, with pressing on around that cage, it should induce osteogenesis.
Yeah, give you that extra compressibility after you've already distracted. That's great.
And right till I get down to there, there's a nice feeling. It starts pulling in. And then that's it. And this will come out. Guide wire's out.
Excellent.
So you
Same.
can throw a couple of stitches here and some Dermabond on that upper one that's just a stab incision. And
Yeah, I love how small that top incision is. That's great.
Yeah.
What in terms of post-discharge instructions, are you kind of giving them the same instructions you would for a regular CornerLoc? Did you add anything necessary with the screw?
I didn't really add anything. I discharged my patients. I sent them home with a low profile LSO. No NSAIDs, 7 weeks, standard precautions. Just
Right.
kind of take it easy. I tell my patients no bullfighting, skydiving,
Yeah,
things
exactly.
like that if they
Right,
can help
right,
it.
right. Yeah, stay away from the squats and the sumo wrestling.
Exactly.
So-
Call with any issues.
I do have a question for you, doctor. As a traditional CornerLoc user, posterior approach, what's the recovery and pain level with this compared to CornerLoc?
I think it's similar. I've had the great thing with CornerLoc is my patients would be leaving the ASC. They tell me the pain's already noticeably better.
Yeah, you notice
Noticeably.
it happens almost right after the procedure.
Some other systems that I've used that don't compress the joint that are oblique, it would take a little longer time. With this, patients are reporting that initial pain relief, which is nice. Not only because we have a traditional implant in there, but even if you chose to, let's say, do just 2 screws as opposed to and completely not use the other implant, I think the compression across that joint is where the patient's going to report some noticeable improvement of the pain immediately.
Right away.
Yeah.
But talk about a case where you might use 2 screws as your approach. What kind of anatomy would dictate that approach?
Well, as far as using 2 screws, which you can talk louder. You can. It depends on what you're seeing. I don't know if I would jump in and just use 2 screws as opposed
If
to.
I can't do my bike at the same time as this, it's impossible.
Somebody's coming in on mic. Somebody's hijacked our mic. So yeah, it sounds like there wouldn't be a lot of patients, you would prefer most likely to take this approach.
I like this approach, using the inferior graft if I can. You know, if there's some other reason, insurance or something, I couldn't use it.
Okay.
Because if you've done, SI joint injection, how many times when you look at that inferior joint, it's always the most sclerotic, arthritic.
Absolutely.
You can clearly see that. And I feel like by placing this graft right into where the most arthrosis is in that joint, they're going to do better. So I like the hybrid system.
Okay.
You know, what I love about the screw is that the biggest issue with joint anatomy is the superior aspect of that joint, right? That's the most variable aspect. It's wide and ligamentous.
Right.
That's when we run into issues with posterior implants.
Right.
This oblique approach with the screw negates any issues that you may have there. And you're going to get a good fusion every time, regardless of how that patient has it.
Absolutely. Absolutely. No, that's wonderful. I also think, like you said, that inferior third is also where you see a lot of anatomic variation in the joint. Some people have a very straight joint, some people have a very curvaceous joint.
True.
Getting into that joint can be difficult, and this gives you, again, that level of comfort that I have a screw coming in obliquely that's going to compact that down and make sure everything's tight. So,
Absolutely.
Fantastic system.
Yeah. Are there any questions? Or?
Yeah, any questions from the audience? Otherwise, for those who want to get trained and more experience on this system, how do they get in touch with you guys? What's the best way to do that? And if you have some upcoming events, this would be a great place to talk about.
Yeah, so we will be planning large labs, probably in your neck of the woods sometime soon.
All right, great.
But short term, if you need information, just go to CornerLoc.com.
Okay.
There's a place you can request information, and that'll take you directly to me, and I'll reach back out to you. And
all right, Chris is the
handle all
man
your
for
needs.
your question. Now we have a question from the audience.
So how can you speak about the changes in trajectory when there is sacral dysmorphia? So I'm guessing alignment or with different. Repeat the question so I won't hear it.
So say you have a patient with sacral dysmorphia. How would you change your approach? What things do you have to take into consideration? That's an interesting one. It's not probably something we'd see very often.
No. I mean, like I said, what I was alluding to before, when it was about the screw, is that it's going to go across the joint. So, I mean, if you have to make any changes, obviously, if it's not traditional textbook Netter anatomy SI joint, you can make those changes. I mean, you can still get across that joint nicely from the ilium into the sacrum, and it's going to compress it there. You could always run into some issues as far as initial guide wire placement, but
It's usually
would
not
that
a
be
path that's blocked. Right?
Yeah, would that be a good instance where you would forego the posterior implant altogether and just run 2 screws?
that is actually,
maybe.
Yeah, that could be. Like you said, sometimes you can have that curvature, and maybe an inferior implant is a
Someone's-
little more difficult.
Someone's
and
had a
you can switch it
fracture.
up.
They've had a fracture there, and maybe there's some difficult anatomy to traverse.
True.
Yeah,
That's the
absolutely.
nice thing about this. There's so many options with this system. That whatever's there, right? Because you don't know what you're going to get.
That's
and
right.
everybody's thinking it's always a little funny down there.
It's true.
You have a lot of options to account for any issues you might run into.
Well, great. This was fantastic, guys. We appreciate it. Thanks for coming on.
Thank you,
Great
Doctor.
to see you.
Thank you.
Thank you.
Thanks so much for having us.